Hi, everyone. We're at the top of the hour, so we're going to get started today. Welcome, and thank you so much for joining us. My name is Christina Asa, Scientific Applications Specialist here at Fujifilm VisualSonics at our Toronto headquarters, and I'll be moderating today's session. We have a really exciting presentation for you today on the vascular remodeling imaging of murine vein grafts using high-frequency ultrasound from our presenter, Dr. Margreet de Vries, Assistant Professor at Leiden University Medical Center. Before getting into our presentation, I just wanted to make a couple notes about today's webinar. We are recording the webinar, and the recording will be made available after today. Everyone's lines are muted for the duration of the webinar, but please at any point in time use the Q&A button at the bottom of your Zoom panel to ask any questions you might have. Questions will be answered by our presenter at the end of our session. And we do expect it to be about a 20 to 30 minute presentation, and that will leave us about 5 to 10 minutes of questions at the end. Without any further ado, our speaker today is Dr. Margreet de Vries, who received her PhD from the University of Leiden in the Netherlands in 2014 and works as an assistant professor at the Department of Vascular Surgery of the Leiden University Medical Center. Her lab at the Vascular Surgery Department of the LUMC focuses on vascular remodeling and vascular imaging. A major focus now is the role of outward remodeling and flow changes within the arteriovenous connection and systemic cardiovascular changes thereof. She is a visiting professor of the Division of Vascular and Endovascular Surgery at the Brigham and Women's Hospital, Harvard Medical School in Boston, USA, where she works on novel in vivo imaging strategies and dietary restrictions. So without any further ado, Margreet, I'm going to pass things over to you.
So I would like to start with thanking the VisualSonics to give me this opportunity to present our data here. So the data that I will present today are unpublished data and work in progression. And so if you have any questions on this, I hope I can answer your questions. So here's a small outline of the webinar. So we study murine vein grafts, and we use ultrasound analysis to see how we can improve outward modeling by performing therapeutic strategies. And the strategies that we're now working on are dietary methionine restriction. For this study, I got a nice travel grant from VisualSonics. Another study where we did a lot of longitudinal 3D volume measurements is the OUT1FC therapy study. And we did some strain and stress measurements in mice, wild-type mice and atherosclerosis-prone mice that I want to share with you. So within these three studies, I hope I can give you a detailed characterization of the vascular function as we perform. And I want to end with a new study that we started recently, and that's on photoacoustics for vascular research. And now I will first see if I can change my laser pointer to a laser pointer. Yes. So here, our study subject in this case is the bypass graft, and this is used both in a coronary situation as in peripheral situation, where a venous graft is used to circumvent a atherosclerotic occlusion, and the bypass is used to provide nutrients and oxygen to the underlying tissues of the occlusion. Here you can see a CT scan of, in this case, a vein graft, and here an arterial graft. Ideally, arterial grafts are used, but these arteries are less common to use as a bypass, so most times venous grafts are used. Unfortunately, the patency rates, especially on the long term, are not that ideal. So in the case of the coronary grafts, up to 25% occludes within the first year, mostly due to thrombosis, and up to 10 years, 50% is occluded. When we look at the peripheral grafts, these are much longer grafts in the legs. Thrombosis is not the biggest problem, but they occlude faster than the coronary grafts, and this mainly due to intimal hyperplasia and atherosclerosis formation, as can be seen on this schedule of the pathophysiology of the vein graft lesions. At the start of the surgery, we already have an atherosclerotic prone situation locally where the bypass is placed, and the bypass itself, the vein itself, is damaged by ischemia and reperfusion. This causes endothelial cell damage, which triggers a thrombotic response on the luminal layer, and this attracts inflammatory cells like monocytes and T cells. They invade the vessel wall, and they start to produce all kinds of growth factors and cytokines and chemokines, which can lead to smooth muscle cell proliferation and migration. If the atherosclerotic situation still exists, so the patient still has a high cholesterol environment, then also a accelerated form of atherosclerosis occurs. And here you can see an example of a patient that 1 year after its bypass graft has a fully occluded, because there's still a really small lumen left, occluded bypass, mostly due to smooth muscle cell proliferation and migration. So these are the three processes that are mainly involved in the pathology: thrombosis, inflammation, and remodeling. And in our group, we study mostly inflammation and the effects of remodeling. For this, we use a murine vein graft model. In this model, we interposition a caval vein of a donor mouse in the carotid artery of a recipient mouse. Here you can see the surgery directly after the vein directly after surgery, and within 4 weeks it dramatically remodels. When we compare the vein graft with the original carotid artery, you can see that it's much bigger in size. Depending if we use a wild-type background or atherosclerosis-prone background, we see a larger lesion in that atherosclerotic-prone mice that consists of cholesterol clefts, foam cell formation, calcifications, and plaque angiogenesis. Whereas in the wild-type mice, we see mostly smooth muscle cell accumulation and extracellular matrix. Here you can see an example of a volume 3D measurement, volume example of a vein graft after, I think, 1 week after surgery. Looking at the inflammatory cell content, we did a FACS analysis, and we could find in this CD45 positive population that there are T cells present, both CD4 T cells and CD8 T cells, B cells, monocytes and macrophages, and dendritic cells. So one of the biggest analyses that we perform within our studies is the histological analysis of these vein grafts. And here you can see an example where we stained for both a macrophage marker and CCR2 to distinguish the pro-inflammatory macrophages. When a vein is placed in the arterial circulation, it has to adapt to the arterial blood pressure. Ideally, the vein extends a bit, it increases the medial size and the intimal size, and it at least preserves or even enlarges the lumen. But quite often you get a negative remodeling or an inward remodeling, where we get a smaller lumen, increased intimal hyperplasia, and also thickening of the media, as you can see in this picture. Although histology is mostly used for these type of studies, we have seen that this doesn't reflect the in vivo situation that much. So that's why we now use ultrasound analysis. For this, we use the Vevo 3100 LAZR-X system, which is an ultra high frequency ultrasound with in combination with photoacoustics. And I find this schedule also always very telling, because here you can see where the different imaging modalities have their strength. So when we look at ultrasound imaging, It's very good in anatomy and physiology. You can also do some molecular analysis with it. And the photoacoustics is a form of optical imaging, and that's very strong in metabolism and molecular imaging. So the combination almost completely covers all the areas. So this is the theoretical scheme of the ultrasound wave. So a high frequency ultrasound signal is sent from the transducer. Tissues start to respond by resonating the fluids in the tissues. That gives a reflective wave that is taken up by the receiver component of the transducer and is built into an image. If we compare conventional ultrasound with ultra-high frequency ultrasound as used in this Vevo machine, then the resolution is up to 300 micrometers within this conventional ultrasound, and with a 30 to 70 kilohertz ultrasound, we can reach a resolution of 30 microns, which is ideal for imaging of small animals. So going back to imaging of the vein grafts, here you can see a longitudinal axis measurement. So here we have a transducer on top of the mouse, and we image in this direction. After 7 days, you can see here on the EKV that we have quite a straight vein graft with a not clearly remarkable vessel wall, because we don't have that much elastin in these veins. So we really need these EKVs to study the movements of the different tissues in these images. If we compare this with 28 days, you really see that the vein graft remodels both in the longitudinal direction, but also in these directions. And the vessel wall is enormously increased in these mice at 28 days. We also always perform short axis measurements, and here this is combined with the Doppler flow. Here you can see both the jugular veins, the contralateral carotid artery, and the vein graft. This measurement is ideal to do quantitative measurements and 3D reconstructions. So within these measurements, we can do 2D measurements and 3D measurements. And in this case, we have a MIP rendering, and this is a control animal where we don't have any vein graft. So you can see that both the carotid arteries and the veins are quite the same size. But if we perform the vein graft surgery, you can see that in this case, the vein graft is quite big, somewhat bigger than the contralateral carotid artery. The parameters that we measure in these vein grafts are the area measurements and now the 3D volume measurements. We can look at pulse wave, we can measure strain, and with the photoacoustics, we can look at the composition. So going back to the therapeutic strategies. So one of the strategies is dietary restriction. And it's all for a long time known that caloric, protein, or amino acid restriction extends the lifespan and decreases age-related diseases. But it's now also investigated that only short-term preoperative dietary restriction, which is easier to compile to, reduces overall mortality, in this case in a model for acute kidney ischemia. Now, the same group in Boston has shown that preoperative protein or methionine restriction preserves wound healing and reduces hyperglycemia. So the hypothesis for this study is that preoperative dietary methionine restriction reduces vein graft disease, and this is via a PFAT, perivascular adipose tissue dependent mechanism. So the idea is that methionine restriction causes hydrogen sulfate release, and the hydrogen sulfate release diminishes all kinds of ischemia reperfusion damage, endothelial cell activation and damage by reducing ICAM and FICAM expression, by diminishing leukocyte adherence and transmigration, and in the end, by reducing smooth muscle cell migration and proliferation. And with all those processes, we see hopefully less intimal hyperplasia. But why do we want to look at a PFAT also in this case? So PFAT is known to affect the vessel wall by keeping the vascular tone and wall remodeling by releasing vasoactive mediators. And one of the most important vasoactive mediator is hydrogen sulfide. So in pathological conditions, you have less hydrogen sulfide, and then you get a pro-inflammatory response. So in this study setup, we compared two situations. So we had vein grafts where we removed all the PFAT. Here you can see an in vivo example. So you really see the blood in the vein graft. And we had a situation where we left all the PFAT intact. So this is the whitish region, as you can see here. So the study setup was as follows. We had mice on a high-fat diet to reflect more the clinical patient situation. And 1 week before the surgery, the mice were put on a methionine-restricted diet, or one group was put on a methionine-restricted diet. This group got a diet that was caloric and energetic equal to the control diet, only with the control diet has a couple of percentage of methionine and cysteine in the diet, and this was completely reduced in the methionine restriction diet. So after this diet period, the vein graft was placed, and the mice were left in for 4 more weeks. And at 2 weeks and 4 weeks, we performed ultrasound analysis. So when we look at the weight of the mice, we see that the methionine restriction diet, they reduce weight, although they get the same calories as the control group. And after the diet stopped and they were put back on the high-fat diet, they increase in weight in comparison, almost equal to the control group. So we performed ultrasound analysis, and in this case, we used the Vevo 2100 system. And here you can see an example of the measurements, and here you can see the vein graft. And with these analysis, we performed a lumen diameter quantitative analysis. And we could see, if we compared the 4 different groups in this study, so control minus PFAT, control with PFAT, methionine restriction without PFAT, and methionine restriction with PFAT, that in all groups, of almost all groups, we saw a decrease in lumen size between the 14 days and 28 days, but this decrease in lumen size was less affected by the methionine restriction than the control group. We also did endpoint histological analysis, and we saw that if we compare the control with PFAT, or without PFAT, and with PFAT, that there was no significant differences, and there was also no significant differences between the non-PFAT group and the non-PFAT plus methionine restriction, but the methionine restriction had the most effect when PFAT was present. So between the control plus PFAT group and the methionine restriction plus PFAT group, we saw an enormous decrease in the intima plus adventitia area ratio. This same effect was seen in the thickness, and this was mostly caused not so much by a difference in intimal area, but mostly in an increase in media adventitia area in the methionine restriction plus PFAT group. But how is this caused? So we did bulk RNA sequencing on the PFAT, and we could see that if we give the methionine restriction diet, that there were quite some genes that were affected by the methionine restriction, but even more genes were affected by the surgery itself when we compare PFAT before surgery and PFAT 1 day post-operative. If we look at the pathway analysis and we look only at the PFAT itself, then all kinds of pathways like thermogenesis and oxidative phosphorylation are affected. But when we look at the methionine restriction effects, then we see a lot of effect on the AMPK signaling, focal adhesion, and lysosomes. So when we look at individual genes, then here we have 2 genes that are really interesting and are really known to be affected in an atherosclerotic situation. This is lysyl oxidase and tennessine C. And tennessine C, that's something that we find very interesting because we have shown previously that tennessine C is highly expressed in the vein grafts. And this is tennessine C is a ligand of toll-like receptor 4. And we have shown in the past that if you use a knockout of toll-like receptor 4, then you really diminishes the vessel wall area. So toll-like receptor 4 increases the inflammatory response in vein grafts upon lichen binding. And we could also see in our study that we have upon methionine restriction a much better profile in the macrophages. So we have more M2 macrophages and less M1 macrophages. And this was also reflected in the PFAT. So we have a more positive M1, M2 ratio. So now I want to switch to the next study. And this is a study that we performed on TGF-beta signaling. And TGF-beta superfamily, which includes the bone morphogenic proteins, are known to be involved in all kinds of vascular processes like vascular remodeling, collagen production, fibrosis, angiogenesis, and inflammation. In this study, we had a strategy that we provided a ALK1 Fc fragment in the blood of these mice, and that catches the TGF-beta, and it even has a high affinity for certain BMPs away from their receptors, so we don't have a signaling response. So we performed the following study. So we put atherosclerosis-prone mice on a high-fat, high-cholesterol diet. We performed vein graft surgery. We gave weekly injections with either ALK1 Fc or control Fc, and from 7 days on, we did weekly ultrasound analysis upon sacrifice at 28 days. And in this study, we performed volume measurements to look at the vascular remodeling. So when we look at this graph first, where we quantify the amount of lumen area in these mice, you can see that the lumen in the control group stays quite similar over time in the control group, but it really increases and enlarges in the ALK1 Fc group. If we look at the vessel wall, so this is the blue-grayish region in the pictures, then you can see an increase in the control group, but a much bigger increase in the ALK1 Fc group. So these two both determine the effect of the outward remodeling, and we can see that we see an increase in outward remodeling in both the control and the ALK1 Fc group, but that is significantly different at the later time points, like the 28-day time point. So what is interesting in this study is that we compared the ultrasound measurements with the really classic morphology measurements. Then we could see that indeed we see a same effect on outward remodeling with the morphology analysis, but we saw quite a different effect on lumen area. And for us, this is really the confirmation that ultrasound imaging, the in vivo imaging, is really important and reflects much better the situation of the vein graft remodeling than the morphological analysis on especially the paraffin sections. Both the intimal hyperplasia and the vessel wall thickness and the wall measurements of the ultrasound measurements are the results are quite comparable. Besides the wall measurements and lumen measurements, you can also do measurements on the flow and strain and stress. And here now I will give a couple of examples of this. And here we looked at the peak systolic velocity. And this is a study where we compared wild-type animals and the atherosclerosis-prone ApoE3 Leiden mice. And when we look at the peak systolic velocity, then this reflects the higher the peak, the stiffer the vessel wall. So we see quite significant differences between the two strains. But with the peak systolic velocity, we can also calculate the pulsatility index. This is a resistance differential across the vascular bed. And these values are also quite used in the clinic. So it's really good to make a comparison to the preclinical situation to the clinical situation. So the pulsatility index is the peak systolic velocity minus the end diastolic velocity divided by the mean velocity. And these measurements can be easily done in Vevo LAB. And when we compared these two of this pulsatility index between our two strains, we hardly saw any differences. We also looked at the pulse wave of the two strains, and these are at the 28th time point. And what we observed is that we have this classical peak, and especially in the ApoE3 Leiden high-fat, high cholesterol diet, this secondary systolic peak occurs. And that points toward a reduced compliance, which means that this is probably a stiffer vessel. And of course, we can do measurements on the pulse wave, but more interesting is to do measurements on the strain. And then we can measure things like the distensibility. Strain can be measured in several different directions, like the axial direction, the radial direction, and the tangential direction. And this is reflected by the different colors. So this is also still work in progress, but I think this is quite an extension of our analysis that we can perform now in these vein grafts. But we also can do photoacoustics. So the idea of photoacoustics is that you send light in that is absorbed by molecules. The molecules start to move, and the movement is collected by the ultrasound detector. So light in, sound out. And interesting, these absorbing molecules like hemoglobin have quite a specific spectral spectral line in the wavelength. So if we look at hemoglobin, we can distinguish oxygenated hemoglobin and deoxygenated hemoglobin. So the deoxygenated hemoglobin can be measured at a wavelength of 750, whereas the oxygenated hemoglobin is mostly measured at a wavelength of 850. And we can now measure this also in the vessel wall itself when we combine the ultrasound EKV analysis with the photoacoustic analysis of both the channels on 750 and 850. And here you can see an example of this. We can quantify this, as can be seen over here. But at the moment, we are looking into a validation system for these measurements. The Vevo 3100 LAZR-X is provided with 2 lasers, so one from 650 to 900 and one from 1200 to 1800. But besides hemoglobin, there are quite some other absorbing molecules in the vessel wall and its surrounding, like lipids, water, and collagen. And we can do a form of composition analysis with this. So we can make a spectral analysis on this AKV, and we can compare it with spectral libraries or known spectral libraries of the hemoglobin or lipids or other collagen, for instance. And with that, we can ideal curves are produced, and using linear unmixing, we can make these really nice pictures where you can see in yellow the adipose tissue. This can be quantified and a compositional analysis can be performed. We can also do this for lipids and collagen, as can be seen in this picture. But this is really work in progress, but a new exciting field. So I want to end with these conclusions. So non-invasive ultrasound measurements are crucial to visualize vascular modeling time. Quantitative measurements on blood flow and vessel wall stress and strain provide new insights in vascular remodeling. Oxygenation and deoxygenation measurements in the vessel wall are feasible, but we still need some validation of this system. And I'm really enthusiastic about the photoacoustic spectral analysis, where we can investigate lesion composition. So this is the end of the presentation, and I'm happy to take any questions.
Thank you so much, Margreet. That was an excellent presentation. And I just want to remind everyone at this point, we do have time for questions. So if you please input your questions in the Q&A panel at the bottom of your Zoom screen there, that would be excellent. So we have some questions that have come in already, so I'll get started. So this question came in at the start of your presentation. When you first showed your short axis measurements, I believe these were one of the first ultrasound measurements you shared, where you showed that there was an increased size of the vein graft. The person is asking, is that the flow that you see there as well, or is it the vessel wall that we see? Because if it is only the flow, there appears to be a large increase in the lumen, and also they want to know at what time points were these images taken. Again, I believe this was one of your first ultrasound images you shared before really getting into either of those experiments.
So the flow was mostly the lumen, although we sometimes see, if we use that mode, that it overflows a bit into the vessel wall itself. So when we do the quantitative measurement, we do it with and without the Doppler signal, because sometimes you get a very high signal, and then it shows a bit more than the lumen. And I think that this measurement was at 7 days. And now we're also starting doing measurements directly after the surgery. So really at day 0. And one of the challenges for that is that we can have air in the surgical space. So after the sutures are in place, we put some extra fluids underneath the sutures to fill up the space, and then you can do really nice direct measurements of the vein graft.
Great, thank you. So the next question is, are the 3D volumes created using manual segmentation in the software, and was cardiac or respiratory gating used to acquire the 3D images?
Yeah, we used cardiac and respiratory gating, and they are the measurements are set by hand. So in Vevo LAB, there is indeed a automatic system, and we tested that with heart volume measurements, and then it works quite okay. But with these measurements in blood vessels, we still have to set them by hand.
Okay, excellent. So another question, were the vein grafts pressure perfusion fixed prior to histology?
Yes, they were. Which also can be affecting the differences we saw in the lumen size and the measurements in vivo.
All right, great. So another question, my question is that for photoacoustic imaging, do you just classify the components or measure them quantitatively? I mean, can you measure how much hemoglobin and SO2 there is?
We haven't done that per se. Yeah, you can measure it as a percentage of the surrounding, but we had some discussion is what part of the surrounding. Yeah, so collagen in the vessel wall, that's you can measure the percentage collagen in the vessel wall, but the lipid content around it is trickier. So we are still thinking of best way to quantify the composition analysis.
Great, thank you. So the next question, strain and velocity profile are based on, or are strain and velocity profile based on offline data analysis? Are the systems, the ultrasound and laser system modalities in separate units, or are they the same? And what are the effects of any medications studied?
That's a good question. So they're offline measurements, and they're quite time-consuming measurements, I have to say. And what was the second part of the question?
Yeah, and I can answer that. Whether the ultrasound and the laser component are two separate systems or the same, are they in the same unit? And they are in the same unit. It's one multimodal system, which is the Vevo LAZR-X. It has that photoacoustics and the ultrasound together.
Yeah.
All right. Another question here. Can you comment on if there's been any validation or any plans to validate the oxygen saturation measurements using photoacoustics? Yeah, just a little comment on the plans for that.
So the oxygen, the oxygenated hemoglobin and the deoxygenated hemoglobin is, yeah, if you do it in other tissues like in kidneys, it's quite well established measurements. But now in combination with the EKV, so that we really measure in the tiny vessel wall itself, we see that depending on how we position the laser fibers, we get some different effects. So we really have to standardize that system and validate it. And ideally, we want to validate it against another technique, but we're not, yeah, we're still discussing that, and we're not decided which way to go in this. So we're also open to any suggestions for this.
That's great. Yeah, it's always interesting when it's a brand new technology that you're using in the field. And on that front, maybe our last question for today is, have you looked, I know that, this is new information and photoacoustic data is brand new, but did you get the chance yet to look at that lipid analysis across time points or between different groups yet, or are you really more at the preliminary stages of looking at that?
Yeah, we are unfortunately still at the preliminary stages, but there's so much nice things that we really have to prioritize our studies, because also the strain and stress measurements need more attention. So yeah, unfortunately, we're in the preliminary stages and we haven't looked into the different time points yet, but we're definitely going to do it.
All right, great. Thank you so much, Dr. De Vries. I think we'll wrap up for today. And I want to thank everyone so much for joining us today. And thank you, Margreet, for that excellent presentation. I'd like to encourage everyone to please contact us using our web forms on our website, or visit our website for any additional information. We do have upcoming webinars, so please check out that page to see upcoming webinars and register for them, or look at past webinars. You can find us on all of our social media channels, and we also do attend the virtual conferences coming up. For those who are already using our system, we do have an online training portal called the Learning Hub, so please feel free to check that out. We have some nice pieces of training material there. So with that, I'd like to wrap up for today. And again, thank you all so much for joining us, and have an excellent day.